the organizing committee. Dear all, it's great honor of me to make presentation here. I appreciate Professor Serrell and the organizing committee for giving me a chance. Here's the contents of my talk. Introduction at first, followed by inguinal endometriosis, umbilical endometriosis, and thoracic endometriosis. This figure is taken from the textbook of pathology. Endometriosis can develop anywhere in the body. Our familiar ones are here. And you can see today's topics here. And they are in less common site or in rare site. This is a classic figure of endometriosis depicted by Professor Cullen as early as 1920. He already clearly indicated umbilical endometriosis and inguinal endometriosis. I am working for one of the largest referral centers of endometriosis in Japan, where endometriosis in less common site and in rare site are often encountered. So I want to start from case studies. This is the first case. She was found to have multilocular pelvic mass in her annual medical checkup. Ovarian tumor was suggested. What do you think of it? It was peritoneal endometriosis. Even peritoneal endometriosis develops in very weird appearance in some cases. The second one is also what we experienced recently. It's omental endometriosis. The surgery was performed with collaboration of the general surgeons in my hospital. The next case is here. A 33-year-old Japanese newly gravid woman suffered from right-sided sciatica and limping for 2 years. She finally experienced constant pain and limping. We performed CT-guided percutaneous needle biopsy. The diagnosis was sciatic endometriosis. The patient did not wish to undergo operation and had no immediate child hope. So we treated her with OC continuously, oral contraceptives continuously. Her symptoms remarkably improved. Meanwhile, the mass showed no marked changes in appearance in MRI, but it was okay since the disease is benign. The case teaches us a lot of lessons. First, correct diagnosis is mandatory for providing good treatment. In this case, we could make diagnosis in a shortest course since we speculated endometriosis based on her history. Her symptom was related to her menstrual period. Next, we should design a treatment according to the desire of patient and the status of the lesion. So I'd like to look at extragenital endometriosis in different sites one by one. First, inguinal endometriosis. This is our experience of 20 patients, 20 cases of inguinal endometriosis. The table shows demographics. Age at diagnosis was 37 years old. It seems to be higher than that in common site endometriosis. Dysmenorrhea was positive in 70%. Ovarian endometrioma was observed in 55%. As for laterality, right side was dominant, 65%, while the left side is only 25%. It was very interesting. And symptoms were related to menstruation in 80%, and swelling at the lesion was 70%, and pain at the lesion was 100%. So why were the lesions more common in the right? It can be explained as follows. Intraperitoneal fluid is known to circulate clockwise in the abdomen. So endometrial cells in the retrograde menstruation from the fallopian tube are likely to be brought to the right inguinal canal. In contrast, endometrial cells are difficult to reach the left inguinal canal because of the barrier of the sigmoid colon. So MRI is especially useful for preoperative diagnosis of inguinal endometriosis. We distinguished two types of inguinal endometriosis. Type 1 is a cystic lesion in the hernia sac and Nacus canal. Type 2 is a solid mass lesion. The lesion shows low intensity on T2 weighted image and high intensity on T1 fat saturated image as shown here. So in terms of treatment, a radical surgical treatment is recommended in order to suppress recurrence. From inside, we cut the round ligament and put a mark with the suture and isolate the round ligament as in figure D. From outside of the surface of the body, we expose the endometriotic lesion and the extraperitoneal round ligament and resect them and block with the sutured mark at the end. Regarding medical treatment for inguinal endometriosis, only a few studies have been reported so far. In our case series, 8 out of 20 patients were treated with hormonal drugs. As a result, Genogest was effective in 6 patients. Oral contraceptives seemed to be less effective. So you may try Genogest when a patient is reluctant to undergo surgery. Umbilical endometriosis is also a rare type of endometriosis. In a hospital, 0.28% suffered from umbilical endometriosis among all types of endometriosis. We conducted a nationwide survey of umbilical endometriosis in Japan. We collected the data of 96 patients with histologically diagnosed umbilical endometriosis. The average age at diagnosis was 39 years old, which seems higher than that in endometriosis in common sites. But like endometriosis in inguinal. So in general, extragenital endometriosis seems to occur in higher ages compared to common site endometriosis. And look at here, more than 60% are parous, and around a half complained dysmenorrhea. 66% of patients had no history of abdominal surgery, suggesting that the umbilicus is a primary lesion. Nearly all patients had local symptoms. Symptoms were related to menstruation in 77%, and swelling at the lesion was observed in 86%, pain in 81%, and bleeding in 44%. And this table shows modalities and their sensitivity to detect umbilical endometriosis. A physical examination was a sensitivity of 87%, very good. As for the imaging modalities, MRI has the highest sensitivity of 81%. So as for treatment, majority of the cases were treated by surgery. When looking at procedures in detail, out of 87 patients, local resection, including the peritoneum, was in 37%, whereas local resection without peritoneum was in 50%, 50 patients, sorry. In each group, more than a half was treated with umbilical reconstruction. Majority of the patients were without hormonal treatment preoperatively as well as postoperatively. We analyzed a cumulative recurrence rate after resection of umbilical endometriosis. No recurrence was found in resection, including the peritoneum. In contrast, when the peritoneum was not included, the recurrence rate was around 10%. So I recommend a complete resection, including the fascia and the peritoneum if necessary. In this national survey, the number of patients treated with medicine but without surgery was too small to make meaningful analysis, so we didn't do that. The next one is thoracic endometriosis, and these figures are those of catamenial pneumothorax. You can see here the endometriotic lesions of the diaphragm. Here is 4 main clinical entities of thoracic endometriosis: catamenial pneumothorax, catamenial hemothorax, catamenial hemoptysis, lung endometriotic nodules. And among the 4, catamenial pneumothorax is the most prevalent, 73%. A couple of years ago, we conducted a study to address catamenial pneumothorax. We used big medical data of Japan, and from 42 million patients, we could extracted 157,000 cases of spontaneous pneumothorax. 82% was male and 17% was female. And please look at this slide. This slide shows age distribution of patients with pneumothorax. Male patients show 2 peaks at around age 18 and 80. In contrast, the female patients have 3 peaks. 2 peaks at the same age is observed in the male. Additional one is around age 40. We next examine the age distribution of patients with a diagnosis of catamenial pneumothorax. These patients had the diagnosis of catamenial pneumothorax in their record. The peak is around 40, which is consistent with the 3rd peak in the female. So we then subtracted the patients in figure D from the patients in figure C. The result is here, where the peak around age 40 still remains, not disappeared. Why? I think that catamenial pneumothorax is often underdiagnosed because of the patients are usually treated by internists and chest surgeons who are not so familiar with the diagnosis of catamenial pneumothorax as gynecologists. Another reason is that endometriosis-related pneumothorax happens not only during the menstrual period. Here's distribution of pneumothorax with pathologically confirmed thoracic endometriosis. You can see some cases of endometriosis-related pneumothorax occurring outside the menstrual period. Now we go back to our study. We compared catamenial pneumothorax and other type of pneumothorax of women in reproductive age. As a result, catamenial pneumothorax was observed in older ages, more frequently associated with endometriosis, more right-sided, and more frequently hospitalized and more frequently undergoing surgery compared to other types of pneumothorax. Why is catamenial pneumothorax more right-sided? Maybe you've noticed already. The clockwise circulation of peritoneal fluid seems to be the reason as in inguinal endometriosis. Endometrial cells tend to implant the diaphragm in the right side, and the endometriotic lesions may develop into the right thorax. In another study, we examined the patients we treated in a hospital. 18 patients were catamenial pneumothorax, endometriosis-related pneumothorax, and 7 patients were catamenial hemoptysis. As you can see here, age at the diagnosis of pneumothorax was 36 in average, which was older than that of hemoptysis, 29 years old. Other backgrounds shown here are not different between the groups. The laterality of the lesions was interesting. As you can see here, right side is dominant in the pneumothorax as expected, while both sides are equivalent in the hemoptysis. Why? Presumably, catamenial hemoptysis is caused by lymphatic or hematogenous embolization, which affects both lungs at random. To sum up, please look at the table. Surgery is standard for catamenial pneumothorax, but postoperative recurrence is often observed. For catamenial hemoptysis, hormonal treatment is very effective in general. We recently published clinical guidelines for the treatment of extragenital endometriosis in Japan. You can find it in PubMed, and it is free access. The guideline covers intestinal endometriosis and bladder endometriosis as well. This is just for your information. Now I have to close my presentation. Thank you for your attention.